Hi, I'm Dr. Stuart Goldberg. I'm one of the members of the Division of Leukemia at the John Thor Cancer Center, and I also am the Chief Medical Director of a data and analytic company that was spun out of Hackensack called CODA, where we pull data from the electronic health records. So I've been asked to talk about personalized medicine and how that relates to research and use of big and small data, in keeping with the theme of today's conference. So precision medicine has been roughly defined as efforts to match the right therapy with the right patient. And I would argue that in this cost-conscious world, we should probably also add at the right value. Now, as soon as I start to use the word value, everybody thinks, oh, you're just trying to cut costs. And actually, in a precision medicine world, we actually may want to spend more money on diagnostics so that we can then match the right patient with the right therapy, and more importantly, eliminate the waste of giving the wrong therapy to the wrong patient. And hopefully that will help with a net savings to the entire population and also improve the outcomes for the individual patient. So how do we go about finding the right therapy for the right patient? Or in other words, how do we enable precision medicine? Well, in a research conference, obviously, it starts with doing the research. And so the clinical trials have been the backbone, especially the randomized clinical trial has been the gold standard in establishing the right therapies for the right patients. And being oncology, I'm a leukemia doctor, these are some of the trials that got the tyrosine kinase inhibitors on the market, which we did at our institution. Well, after we've picked the trial we're going to do to try to get that matching and beginning the process of identifying precision medicine, we then usually go through our informed consent process, which we just heard about, but then we're presented with an eligibility checklist. And the goal of the eligibility checklist is to narrow the scope of the trial and narrow the type of patients that we enroll, so that really we can focus on, is the therapy or is the outcome that we're looking for, really a result of what we're doing. In addition, randomization, if we do a randomized clinical trial, the goal is to reduce further biases. The problem is, for real-world medicine and for precision medicine, is that once the clinical trial is over and those therapies enter the clinic, the clinic itself, do we follow those same eligibilities? Am I actually going to deny a patient with lung cancer the new promising immunotherapies because they're a little bit older than the clinical trial, or that they have not as good kidney function or something else? So really, the question is, once the therapies are done and we want to start applying these ideas, what we learn in the clinical trial, how generalizable are they? Once we've done our consent and we've got our eligibility and the patient's now on trial, the next thing we're presented with is a complex research protocol. And the research protocol ensures standardization of what we're doing so that everyone, every center, every site, every investigator is doing the same thing. It also ensures safety. It tells us what to do, what doses, how do we monitor the patient, how do we change our doses. How do we, go navigate the system? And once again, then also allows us to do the analysis on the back end. But again, once the studies are over and therapies enter the real world, do we actually follow those research protocol levels? And the answer to that, I can tell you, is a resounding no. I actually chair the International Simplicity Trial, which is the largest trial in CML being conducted right now. It's 1,400 patients, 7 countries, 220 sites. And we asked a simple question in this observational database, and that is, in the real world, once the therapies are on the market, are physicians following the monitoring techniques that were in every single one of the clinical trials? So in all the clinical trials, we were supposed to monitor our patients by PCR monitoring to tell if the patient's responding or not 3 to 4 times a year. And we saw that only about 1/3 of patients were having the monitoring that was in every one of the clinical trials. Once again, questioning the generalizability of research to the clinical world. So how do we go about generalizing the results? And more importantly, how can we learn from all the experiences after the medications, after the therapies have hit the real world? Because only in oncology, less than 5% of patients are put on clinical trials. And we can't really say precision medicine or that we're matching the right therapy to the right patient when we're doing that based on only 3 or 4% of patients, and we don't have any clue what's happening when those drugs hit the real market. So what do I mean by the real world? What is the real world? Because for many of us, the real world is our hospitals and our research trials. But most of us in the field feel that real world is actually just the opposite. It's what do we do outside the confines of the clinical trial. Both the ISPOR and RAND Corporation have presented some definitions, but the commonality is that these are patients that we're taking care of, patients, not subjects, that we're taking care of now outside the world of a clinical trial, when we can do whatever we think is best for the patient. So at that point, we're automatically putting our biases in. We're making assessments of can the patient tolerate this therapy? Is the dose that was in the trial the right dose for this particular patient? And we're choosing among therapies based on our personal biases, all the things we try to eliminate in the clinical trial. We also have been talking a little bit about big data at this conference, and I just remind that big data is not the data, it's actually the storage of information and the analytical techniques. So how do we analyze what's happening once the trials are over? Well, we can go back to the old-fashioned ways of going down to the chart, pulling out charts, doing chart reviews, doing single institution or multi-institution observational databases where we look to see what is being done. Or we can go to the billing records and see how claims are done. These are all secondary uses of information with the purpose of finding out what we're doing after the trials are over. Well, fortunately, in the last several years, though, we've had a new data source that's become available, and you heard a little bit of it this morning, a flavor that, data is out there, and how can we mine into the Googles and your search engines and all the other things when it comes into research in the medical fields? Well, and how can we use that information to help us move towards getting the right therapy for the right patient? Well, we know that over the last decade, we've seen a transition from the paper chart to the electronic health record. And now, as soon as I mention the word EHR or Epic or Cerner or any of the things, there's a cringe, I'm sorry, by all the clinicians in the audience. Because if you ask people what is the thing they hate most about modern medicine, it's the electronic health record. This was a survey done of by the American Society of Clinical Oncology last year, where they asked the biggest frustrations the cancer doctors are having. And it's not the insurance industry, and it's not fighting with patients, and not fighting with all this, it's the EHR, because it's adding hours to our lives, and we feel that we're putting a lot of data in, but not getting anything usable back out. And likewise, if you'd broaden it out to the American Medical Association from their survey a couple years ago, you can see that almost 3/4 of physicians felt that the EHR was not decreasing their workload, and very few felt that the EHR was helping them in their daily lives and taking care of their patients. And yet we're putting all this data in. Why not tap into that so that we can then advance research the same way the Target is doing to figure out whether or not they should be sending out a letter to say, hey, come buy some baby products. There's this information out there, and it can be tapped so we can then advance to see what we're doing after the clinical trials are over. So how did we get to everyone having an EHR? Well, that was spurred on at the beginning of the Obama administration by federal legislation known as the HITAC Act, which included this thing called meaningful use. So the HITAC Act was a way of generating real-world data. The idea was, let's see if we can get out of the paper chart back Stone Age and into an electronic world in healthcare, because we were lagging far behind the supermarkets and the big box stores. Healthcare was still writing notes and writing crappy notes. How do we take that and now make that, all of that information, usable so that we can tap in and find out what we're really doing? So how do you get people to do things that they don't want to do? Because if other industries were doing it, how come medicine wasn't? Well, one of the ways you can get people to do things is you give them money. So the HITECH Act was a $35 billion effort where they said, we're going to give hospitals, doctors money to put EHRs in place. But in addition to buying the EHRs, for which we're going to pay you, you have to use them. You can't just buy it and say, oh, here, thanks, federal government. $100,000 per doctor if they bought an EHR. So this was big money, but you had to use it, and that became known as meaningful use. Now, meaningful use has gone through multiple steps. The first part was just basically buy it and put in a few basic elements like, you know, do you smoke or not, like that. And then and that everyone seemed to be able to do. The second piece was meaningful use part 2, however, was much more complex. And that was, now they started to access to really start using it. And that's where, unfortunately, doctors and hospital systems had trouble meeting some of the requirements of meaningful use 2, which has now been evolved to meaningful use 3, which is no longer meaningful use 3 because it was rolled into the federal MACRC standards. But the bottom line, this isn't a talk about EHRs, the bottom line is that through this legislation, everyone now has electronic health records in addition to having your Target records and your CVS Caremark records and your supermarket records. We now have electronic records on lots and lots and lots of patients, or the ability to at least access, to have them stored somewhere. Now the question is, can we access them to make us move our healthcare forward? So why aren't the EHRs making our lives better, or at least giving us useful information that we can use to move towards precision medicine in the real world? Well, there's been a lot of complaints. One is interoperability. This is sort of the old scapegoat, and that is that my hospital system doesn't talk to your hospital system, and my blood bank doesn't even talk to my pathology department, and neither of them talk to the clinic. That we have bought different systems that don't talk to each other. And that is true, but there are electronic ways in the back end, something called HL7, which is a standard that allows those computers to talk to each other, because guess what? They all talk to the insurance carrier. So there is some back end information that's there, and it's just a matter of us being able to tack those things in to each other. And that has actually been worked out, and there are federal and international standards that are developed to allow the computer systems, the disparate systems, to work. There are also some business reasons, however, why the big computer companies don't want our system to talk to their system, because then you'll buy more of theirs. And there's also some business reasons from the hospital standpoint. The Hackensack Meridian system wants to keep all their patients within the Hackensack Meridian. So do you think that we want our medical records to leak to a competitor network system? Now, we can talk on the ethics of this, but this is some of the business realities. And then there's usability, but those things can be worked out. But then there's usability issues with the electronic health records, and we know that they're clunky. They were never built for doctors and nurses to enter data in, and they were certainly never built for us to get any really information out. They were really built to suffice this billion-dollar giveaway by the federal government, that if you bought the machine and you did what they asked you to do, you were going to get some money. And so when that law came out, the big companies that already had massive systems that could do everything quickly adopted the standards that were needed and quickly became the gold standards for each of our institutions. And so usability was probably just sort of forgotten in the rush to just get the systems into our place. So how do we make the EHRs more useful so that as research nurses you can tap into that data and not have to spend lots and lots of time transferring information to case report books? And how do we, after the research trials are over, tap into all of the experience of all of our patients so that we can understand what we're really doing in the real world? Can we really use the EHR to give us the ideas of precision medicine? Well, there are some things that we will need to re-engineer the way doctors and nurses think. And the first is structured versus unstructured. When you're doing a research trial, you're given a case report book, and it puts everything into little blocks, your Excel spreadsheet. You put everything in so you can then do analysis. If you look at the average doctor or nurse's note, though, it's a text. It's this long, where all the richness of the chart is in that storyboard. It's the 80-year-old woman who comes in with anemia to have the story, and you read the story, but that's not great for research, because we need to then pull all those things out and structure them into little age, sex, diagnosis, those pieces. So we need to rethink the way we collect the data into the EHRs, and if we don't want to change the way we type our notes, and we don't want to make standardizations among programs, and there are groups that are doing this. The College of American Pathologists has now a standard form that they would like pathologists to start keeping their strategies. That will allow us to pull it out more efficiently. But in the computer world, natural language processing and other computer engineering type solutions to read through the notes and pull that data out will surely be coming in the next couple years. It's lagging behind other fields, but it's coming. So, even if we could pull it out though, we then typically, in our current systems and the EHRs and other ways we store data, we tend to store it, once again, thinking in a billing phenomena. We tend to store it in things called ICD-9 or ICD-10 codes, which we're all familiar with. These are the codes that were sort of categorize big diseases, but then they're also then linked into billing codes, and that's how we get paid. So that's how we, in our hospital, we have to put a diagnosis code for every visit we see, and we use the ICD-9 and 10s. Well, if you've looked at those codes, they're very broad. They're like breast cancer or colon cancer. They don't say very much about what kind of cancer other than the big type. They don't tell us all the richness that we need to be able to do research and to understand what we're actually doing, because they're not meant for that. So on the other side though, that's medicine. We also know that if you go into the box store or if you go into your supermarket, they have coded everything. So when you walk into your grocery market and you pick up a green apple and it has a barcode on it, that barcode tells the grocer a lot of information about that's a green apple. And it doesn't just say it's a green apple, it actually, if you swipe that barcode also tells the price, it tells where he bought it, it tells what farm he came from, what his distributor is, and if, God forbid, there's an outbreak of some infection or the cans are disabled, he can then see if he has any of those cans in his shelf. So he can quickly know the tracking of that product from the farm all the way to the table. And yet in medicine, we don't track. If you ask my hospital and my practice in the cancer division, how many patients we saw with breast cancer last year, we'd say we saw a lot. We wouldn't know how many we saw. It would take us a couple weeks of fighting with our billing department to give us the ICD-9 and ICD-10 codes, and then we just know how many breast cancer, but we couldn't tell you how many were stage 1 versus stage 4. And if we don't even have that amount of clarity for taking care of our patients on a day-to-day basis, how can we go into contracting and billing where we're going to get paid differently up front if we go into bundled payments or value-based payments based on, if they say $50,000 for every breast cancer patient, is that a good deal or a bad deal? It might be a good deal for an early stage breast cancer and a lousy deal for a patient with advanced disease who has HER2 expression where they need expensive drugs. But if I don't know what I'm taking care of because I've never did my volumes like the supermarket does, they scan, every couple days, every couple weeks, they close down the store for an evening and they scan their volumes so they know. And not only that, they also know what's selling at what area. So they can know they can move product around. Wouldn't it be nice if hospitals could say, wait a minute, for this particular disease within our network, this is the hospital you should be at. Or the simple ones maybe at the community centers, and we'll move the more advanced cases to our big academic, academic center within the network. Or we'll know what the quality is between the different centers. We don't do that because we don't track what happens once the patient leaves the research world. Once they go into the community, and once the drugs are out there and the therapies are out there, it's a free-for-all. You can do everything you want at any center you want with nobody looking over your shoulder and nobody tracking. And yet, every single one of those patients has now an electronic health record. Google, Target, they would track every single patient at every step of the way and be able to tell you what the quality was at each of the individual places. They would tell you which stores are selling, which stores are not. But medicine doesn't do that. But we now have the ability to do that because we are tracking what's gone done, where the patients are by knowing from an EHR. But we still need to put the barcode on every patient's disease. So I think Dr. Gua talked a little bit yesterday about some of the efforts we're doing at Hackensack and some of the things that we've done over the last several years with our barcoding idea. And so we actually now, for every patient who walks into the cancer center, as well as for actually half of New Jersey, we are now tracking every cancer patient by putting a barcode on something we call the CNA. And this doesn't happen only to do with oncology, we're actually starting it in mental health now. So if you think about it, how do you develop a barcode system for all of medicine? Well, the first thing you do is you say, okay, what field of medicine there is? You know, build an encyclopedia. So you have your book that's for cancer, and you have your book for GI, and your book for rheumatology, and your book for orthopedics. So each disease entity has a sort of a book to pull out. Within each book, you have different chapters depending on what kind of subtype of disease. So in the book of oncology, you might have breast cancer and colon cancer and lung cancer, some of the big, each of our divisions. Going down past that, within the chapter, you may have different subtypes, like for GI diseases, GI oncology, you may have colon cancer and anal cancer and pancreas cancer. And you start building your taxonomy down to very, very finite levels. And then you start to get rule sets and start getting combinations of this. So you basically build a barcode system for every patient, which we've done. So what you see here in this slide is a woman with breast cancer. And the barcodes on the left, the first couple digits say that she's got breast cancer. The last several digits say where the patient is in the course of their therapy, whether this is the first treatment, second treatment, and third treatment. And that middle piece, that what we call the phenotype, is all of that information on what type of breast cancer the patient has. Is this for stage 1, stage 2, stage 3, stage 4? Is this hormone positive, hormone negative? Is this patient have genomics that are important, or genomics are not important? What is their race? If that's important because that is important in breast cancer. We know that African Americans don't do as well if it's triple negative. We can look at the socioeconomic status if that's important in determining prognosis. So you put all this stuff in, and the bottom line is you develop a barcode system. So if every patient's disease is now barcoded and properly classified, how can we use this to enable precision medicine? All pulling this out of the data that's readily available already in the EHRs. So this is actual data from the state of New Jersey on over 3,000 consecutive patients with breast cancer, where every single patient was barcoded as they came through the system. And what you can see is that although we went from breast cancer being one code in ICD-9 to over 5,000 different variations, the big tumor that's hormone positive, the little tumor is hormone positive, over 5,000 different combinations, we only used about 200 of the combinations because certain things group together. And what this shows you is the population frequency of the different types of breast cancer. Just like if you went into your grocery store and you see, well, you have a lot of this, and these items don't sell so well, so you only put a couple of them on the shelf. So we get an idea of what these things are. Now, if you look at if you're into the population health sciences, or if you're an insurance carrier, you're going to focus on those ones that are on the left, the most common subtypes, to find out what are they, how do they do, and how do they cost? What's the cost? That's how you can build your ideas on how we should price in a value-based world. And it turns out in breast cancer, the ones on the left are typically middle-aged to a little bit older women, usually in good performance status, who have, very little in the way of comorbidities. They typically have smaller tumors. They're typically hormone positive and HER2 negative. These are the good kinds of breast cancer, and it basically shows that in an affluent state like New Jersey, screening is working. And so that we're picking up mostly healthy patients who can tolerate therapy, who are being screened and being picked up early stage. If I showed you the same graph for lung cancer, unfortunately you'd see a marked shift, and you'd see a lot of advanced cancers, because in general we know that patients are not picked up with lung cancer until they're more advanced, unless you happen to live in Bergen County. And here's how you can start overlaying other data sets. Because in Bergen County, where many of the hospitals have low density CT scans and screening studies, we see a marked shift towards earlier stage, showing us that screening, actually in lung cancer, can have an actual impact on what we're seeing. Now, we sort of know that from the research, but to see it play out in real world is actually nice, and it can tell you when you should invest in buying these machines and are your screening techniques working, because we can actually look at, not that we just picked up lung cancer, but we picked up lung cancer at an early enough stage where we can actually do something about it. So take that same curve and now lay it on its side. Because now we want to start saying, okay, we have patients that we know what kinds of breast cancer they have. We've barcoded every single patient, so we know what they have, and let's see how the doctors are treating them. And what we're starting to look for now is variance, because you want to see that the doctors, when presented with the exact same patient, are treating them the same way. And if they're not treating them the same way, if there's a variance, why are they treating them differently, and is there some way we can optimize the care to get the precision medicine, to give them every woman with the same exact disease the same best therapy? So what you can see here is on the top curve, that is the most common breast cancer in the state of New Jersey, which turns out to be a small tumor in a healthy woman. A lot of other things that are all the same are sort of typically healthy women who has a small tumor that's hormone positive and has a low genetic score called an oncotype, where we know that from research data that these women can do extremely well with hormonal therapies and do not need chemotherapy. And what you can see is that 96% of the patients in the state of New Jersey who present with that to multiple different physicians are treated exactly the same way. They may use different hormones, and we can delve into that, but at least the strategy is the same. So there we have precise medicine. We know that the genomics tell us what to do, and doctors are actually following that. That third curve on there, however, is the same exact woman as far as her other medical health, and the same size of the tumor, same stage. The only difference is her genomics were a little bit higher risk, so-called intermediate genes on the Oncotype test. And what you can see is that half the women are getting chemotherapy and half of them are getting hormones. But they're the exact same woman. They're the same age, the same size of tumor, the same this. And it just depends on where you go and what the doctor was feeling like that day. So it's telling us that in that particular disease, we can identify that there's a variance. And variance is our enemy, because it means that we're not being precise when it comes to precision medicine. We're not saying we know something about this tumor and therefore this is the right therapy. Now in this case, it's actually a science problem. We don't know the medical right answer. Is it better to give chemo or hormones? And the literature is all over the board, and there are big national studies that are being looked at. So here's a knowledge gap. But in other diseases, we're finding that there are variances that we actually do know what the right answer is, and we can identify when people are not doing the right thing and try to drive them then to doing it. Finally, we should always talk about costs, because costs are going to be more and more important. The mantra that we have in our system, in our company right now is, if we don't come up with a rational way to treat patients, we're going to be stuck with rationed care. And so, because the economics of what's happening in healthcare, we need to come up with rational ways to do things. And so using a barcode system, again, we've looked at now about 200 and some odd patients for one particular hospital, and we looked at how the patients were treated by the different types of breast cancer, not just lumping all breast cancers together. And we start to see patterns emerge, as certain breast cancers were treated in certain ways, and the costs were and there was somewhere very tight. Everyone's getting hormones only, the tight distribution in the costs. Other diseases where, if you were thinking that half the people are getting chemotherapy and half of them are getting hormones, you can see that the cost distribution is fairly high. And this is that third curve. This is the same exact disease, same exact patient, treated by different physicians, and we can start to look at, is there a difference in the doctors who are giving one versus the other? Is there a difference in costs because of where they're being treated? So once again, by barcoding everyone, we can now start to get to the variances, which is the enemy of precision medicine. So what are some other examples of how we can enable precision medicine by going into the electronic health record? So I think this is a curve that Dr. Guam may have shown yesterday. We actually got this accepted for publication this week, where we looked at 800 and some odd patients throughout the state of New Jersey who were undergoing diagnostic evaluation for lung cancers. So under the current American Molecular Pathology and the College of American Pathology guidelines, you're supposed to look for certain genomics in every patient with lung cancer. And these recommendations have been around for the last several years. They were all based on good research done by men and women like you. We know that this is what's supposed to be done. The question is it being done in the real world? And what you can see on the left-hand side is that only about 2/3 of patients in the state of New Jersey actually got the 2 most common genomic profiling. And yet when you ask the doctors, of course I profile, that's the CAP guidelines. But when reality comes out and you start looking at what the doctors are actually doing, we find that we fall short. And once we get past the 2 big genes and you start to go into minor genes where we may have research options or experimental therapies, it trails off dramatically. And the reason this is important is on the right-hand side, and that is real-life data survival. This is progression-free, and I can show you the same with the overall survival. In the field of lung cancer, if you have a gene and you get the right therapy, the targeted therapy, you add 3 more years of life. So we found that 1/3 of patients are not being tested, and those patients don't have a chance to have 3 more years of life. So precision medicine sounds good on the paper, works in the research world. Can it be translated to the real world? And how do we monitor this in real enough time that we can make difference in our patients' lives? And that is the challenge. And fortunately, with the EHR, hopefully we can pull that data out fast enough that we can feed that back into the hospitals and say, hey, this doctor's missing it, or you're having a system breakdown. It often is system problems. The labs aren't getting the sample fast enough, and so you find where the system breakdown is. Here's another example. This is actually from our own institution, where we looked at, as you may know, Medicare is changing some of its payment models to do a value-based system. There's something called the Oncology care model, where they're looking at how you perform over 6-month intervals. So there's an expensive genetic test I told you in breast cancer called the Oncotype Dx study, which costs $4,000. But then that test may then inform you as to right therapy. So it enables you to do precision medicine. But it costs $4,000. So if I'm being pressured to try to bring down my costs, do I really want to spend $4,000 on every patient with breast cancer? So what we did was we looked at how patients at our institution, if they had the test, did it change treatment? Did it lead to better outcomes? And did it change the costs? And it turned out that for stage 2 breast cancer patients, where the tumor is a little bit larger, the genomics actually did change the way the doctors were going to treat the patient. They used that information and actually changed it in a way that most of the women got less chemotherapy, had just as good outcomes, and cost a lot less. So that should tell us that every single woman who comes through the system with that size kind of tumor should be tested genomically, because the $4,000 you spend, you recoup $11,000 on the back end. On the other hand, if you had a very tiny tumor, a stage 1, it turns out that, yes, the genomics could predict if the patient was going to do well or not, but it very rarely changed the treatment. Only 2% of women with stage 1 tumors did the test actually change the way the doctor was going to treat it. And so now you were paying $4,000 extra for every single woman, even though it wasn't going to change your treatment. So yes, we have a precision diagnostics, but it's not being applied in the real world appropriately. Just because the research study said, hey, this does predict, you then have to look at is it going to change the way doctors are treating people? And so precision medicine, yes, but precision medicine that makes any value sense, absolutely not. So in summary, I think I would like to say that precision medicine and using the idea of getting the right therapy to the right patient is something that we want to be focusing on in a value-based world. And unlocking the value is going to require precision analytics, all those fancy genomics and all those fancy things that we do in the research world. But we're really going to need to discover who's doing the right things to the right patient, and then try to use this information to correct behaviors so that every one of our patients, after the research trial is completed, gets the right therapy and can benefit from the world of research. And with that, thank you very much.